So now let's talk asthma. Asthma is a chronic condition that people live with every single day for most of their lives, but also an acute condition. So patients will walk around, they've got a history of asthma, they walk around every single day, they're just fine. Um, Here they've got a normal airway, they've got normal bronchi, bronchioles, and they're moving air in and out just fine, and then something exacerbates their asthma and sends them into some sort of like bronchial inflammation here. So the airway narrows. We've got some inflamed bronchial walls, a little bit of mucus secretion here. And this is what causes our asthma symptoms here. So if we're thinking, VQ ratio wise, so now we've got an issue with ventilation. We don't have an issue with perfusion, but we've got an issue with air moving in and out. Some risk factors for asthma. You can just be predisposed to have asthma, to live with asthma. So looking back into family history, asking a good family history during your assessment goes a long way. And then we got atopy, which is just a genetic predisposition um, to asthma. So, asthma and eczema and allergies kind of falls under this category. So, getting a good family history, and then some people, even without that family history, are just predisposed to developing asthma and suffering from asthma. Then we've got some causal factors that research has highlighted. There are certain allergens that people react to. Both kind of occupational and environmental. So these allergens, once we are exposed to them, we're gonna have a little flare up of asthma. Then we've got some contributing factors. So we've got these occupational factors that might kind of cause asthma, but definitely these contributing factors. Smokers or just being exposed to smoke, kind of that secondhand smoke, can cause some airway inflammation. Airway pollution, we've got exercise-induced asthma, which is a real thing. If you ever heard it and kind of pass it off as nothing, some people have exercise-induced asthma. So when they exercise and kind of strain their respiratory system, they kind of kick in a little bit of airway inflammation, and then even diet. So, for certain people, diet can go a long way in controlling asthma symptoms, or even go a long way into producing inflammatory responses. Signs and symptoms of our asthma patients, obviously dyspnea, big fancy medical word for shortness of breath, having a hard time breathing. It's going to be all of our respiratory patients, but they're going to have dyspnea, but they're going to have wheezing. So this is an expiratory whistle when you listen to lung sounds. So inspiratory whistle is stridor, expiratory whistle is wheezing. Your asthma patients can have both if they have both wheezing and stridor. That means that the airway inflammation, airway constriction has moved its way all the way up into the upper airway, and that's a bad day, and you need to be moving pretty quickly to treat these patients. But most of your asthma patients are going to have wheezing, that expiratory whistle when you listen to lung sounds. They might have coughing because remember there's going to be a little bit of mucus production along with this asthma exacerbation. So they might be coughing a little bit, and they might be coughing up a little bit of white sputum with that cough. What can we do? Well, let's start with oxygen, right? Let's increase our FiO2, that fraction of inspired oxygen. So let's bump it up from room air at 21% and put them on a non-rebreather at probably pump it along at like 98%. So let's put them on oxygen first, but that doesn't really help or fix our VQ ratio issue. It doesn't fix air going in and out. So we can increase FiO2 all we want. If that's all we do, now they're still not moving that oxygen in and out down into the alveolar space. So we're going to have to do something to open up those alveolar spaces. We're going to have to do something to kind of recruit those alveoli. So what we're going to reach for first, probably albuterol, probably ipratropium or Atrovent. So remember, our albuterol is a beta agonist, a beta 2 agonist. So beta 2 affects the lungs, beta 1 affects the heart. Albuterol is a beta 2 agonist, still has some beta 1 effects, so we have to be a little concerned about cardiac effects on our patients. But albuterol is going to be our beta agonist. That's a short-acting beta agonist, so we can give that in the short term. It's not going to be, the half-life there isn't going to be super great or super long. So you give albuterol, we can give ipratropium or Atrovent. That's our anticholinergic. Because remember, our asthma patients, they've got that inflammation, they've got that swelling, they've got some mucus production. That anticholinergic is going to dry them out. So we're giving albuterol to hopefully bronchodilate a little bit. We're giving ipratropium to dry them out a little bit, that anticholinergic. We can go a little bit further, and you might see your chronic asthma patients on these at home. You've got formoterol. That's also a beta agonist, just like albuterol is. But albuterol is short-acting, but formoterol is long-acting. So they can take that once a day. That lasts them all day. Kind of keeps them open all day long for your kind of chronic asthma patients. You might also be taking Singulair. You're going to see Singulair a lot with our asthma and our COPD patients, but a lot of asthma patients are on Singulair if they've got chronic asthma. These are our leukotriene receptor agonists. If you don't quite remember what a leukotriene receptor agonist is, that's okay. You can go back into our Big Pharm EMC 320 pharmacology lectures and kind of catch yourself back up on leukotriene receptor agonists. This covers most of our asthma patients that we're going to encounter out in the field, but what happens when we move into status asthmaticus? So this is an asthma patient in an asthma exacerbation, and they are now unresponsive to bronchodilators. So you're getting called out, 911 call, and these chronic asthma patients, they are probably on an albuterol nebulizer at home. They've got a nebulizer machine at home. They might even have Atrovent at home. They might have everything we have on our trunk at home, and they've tried it. So they've tried their albuterol treatments, they've tried their Atrovent, they've tried everything, and it's not working, and that's when they call 911. So these are the patients we really need to worry about. So our kind of run-of-the-mill asthma patients, we can give them a Duoneb, and that Duoneb is just a combination of albuterol and Atrovent and ipratropium, and they're fine. But our status asthmaticus patients are going to be the ones who have a long history of asthma, long history of asthma exacerbation. They know how to treat it at home. Listen to these patients. They know themselves better than we do. They know the treatments probably better than we do. They know these medications. They've tried the albuterol. They've tried the Atrovent. They've tried it all at home, and nothing is working, and that's why they called 911. So now we are unresponsive to any of our bronchodilators. So what we have in our box of tools that they don't, we've got mag sulfate and we've got methylprednisolone. So mag sulfate, just magnesium, is a smooth muscle relaxer. We can give mag, so 1 or 2 grams over 10 minutes IV. We can give that for a smooth muscle relaxer, and we can give solumedrol or methylprednisolone, 125 milligrams. Give that IV. That's a steroid. That's an anti-inflammatory. So we're trying to reduce inflammation on both ends here. So our patients aren't going to have mag. They're not going to have solumedrol. So we can try albuterol. We can try our Atrovent. It's probably not going to work for these patients. So we're going to go pretty quickly to mag and solumedrol. And then in the back of our heads, we're going to be considering intubation and considering RSI depending on how our patients react to our treatments. As you encounter asthma patients, as you assess your asthma patients, we want to be asking very specific questions, and we want to kind of take into account or keep in the back of our head these risk factors and risk factors for death due to asthma. So kind of how serious is your asthma patient, or how serious could your asthma patient become? So we're going to do this 1, 2, 3 ASAP mnemonic. So if there's been one prior intubation for asthma, ever, because of asthma, have they been intubated? That's a huge risk factor. Have they been hospitalized hospitalized, there we go, hospitalized within the last month for asthma. Huge risk factor. Have they had ever 2 or more hospitalizations for asthma? So 1 hospitalization within the last month, or 2 overall ever within their life. 3 or more emergency department visits within the past year is a large risk factor. And then as you assess them, have they experienced syncope? Um, are they not alert? Is there an altered level of consciousness? Are they dependent on steroids? So remember, one of those tools in our box is solumedrol, that methylprednisolone. Are they already on that? Are they already on a steroid? Because if we give them another steroid, that's not going to do anything. Access to healthcare is poor, especially in these rural areas, out in Jackson County, Haywood County, west of us, north of us, south of us. Access to primary health care is pretty poor, so they're not getting a whole lot of follow-up care. They're not seeing a specialist a whole lot, right? They don't have a pulmonologist, I'm guessing. And then any psychosocial problems, so any social problems, any social barriers to care. So when we're thinking about risk factors for death due to asthma and risk factors for just our patient decompensating pretty quickly or becoming a critical patient, we're thinking this 1, 2, 3 ASAP mnemonic. If you have any questions, concerns, comments, or cuss words, please let me know.